I request Dr. Shambo Begum ma'am to please come and felicitate Dr. Shantanu Munshi sir. Professor Shantanu Munshi sir. Sorry. Thank you.
So now we come to the last presentation of this conference. The last batsman for the last 6. The topic of the presentation is clinical pharmacology review, reconciliation, and feedback. And this, Shambo, this terminology you should patent, because it is his terminology, and that is the first time that I ever heard about it. And he continues to persist with this, which is very remarkable. So go ahead and best wishes for the presentation.
So thank you, sir. And actually this terminology is patented by my mentor, Professor Tripathi, sir. I see, okay. Because even when we are preparing some topic on clinical pharmacology reconciliation, so I have a regular habit of sending my PPT to Professor Tripathi before any presentation. Now I am a little bit unfortunate that sir sometimes make my mails mostly in the unread folder. But that day I was fortunate, and sir had edited some portions, and from that I got that terminology. And after getting that terminology, I was just want to publish that also. So we are really fortunate we got some publication on that issue. But thank you, sir, for your comments. So this will be, this is the last presentation, yeah. So okay, go ahead. So I have a small announcement. As yesterday there was no quiz session, so Dr. Shabnam Begum and Dr. Bhaskar was very keen to conduct the quiz. So in between my presentation, I had prepared some MCQs for you, and I am fortunate that the Dr. Shabnam Begum is here. So as she is also going to most probably host a couple of DM students in near future, because she had opened a clinical pharmacology department, that is course in ACPICON Medical College. I don't know how many of you postgraduate students are actually watching us. So you have a provision of DM in clinical pharmacology from ACPICON also under Madam. So Madam had announced who will give the maximum answer to the MCQ questions. Madam will give some awards. Okay. But again, the disclaimer is that I will ask Dr. Anindo Karmakar not to participate, because you know this presentation. Just 1 week back, we had together present this. So the question is already out to you. So other can participate. So let's start today's discussion. And I think
3 minutes gone.
If it is 15 minutes gone, so I think Dr. Shabnam Madam will be very happy, because she had to give less price. So this is a picture I always prefer. I always salute them, and I think many of you are very keen to salute them, these CRPF Jawans. And when we talk about this CPRRF, we also need to be vigilant like these CRPF Jawans, so that there should not be any ball missed by us. So what is CRPF? or rather our CPRRF, this is clinical pharmacological reconciliation, review and feedback. So these 10 points we had proposed, and this had been very recently published in JCP, Journal of Clinical Pharmacology, that first of all we need to evaluate whether our prescribed drugs are appropriate or inappropriate, whether we need to do the deprescribing the inappropriate drugs, to identify the omissions or commissions during the transition of care, which is a very critical period, tailoring the dose adjustment to the individual need and perspectives, and preventing, minimizing, managing the adverse drug reaction, improving treatment adherence as Dr. Munshi had mentioned, affordability and availability, how to improve the adherence on that issue, and individualization of therapy. Along with, we need to tackle the polypharmacy, specifically when we are seeing the geriatric patient, and ultimately enhancing the quality of life. So, patient-oriented evidences that matters more, that is POEM, patient-oriented evidence that matters. So, POEMs is always preferred over DOEs. What is DOEs? Disease-oriented evidences. So we have to be more patient-specific. So first question to you all, which is the correct option? Select the correct sequence in increasing order for the leading cause of death in US. So option A, cardiovascular disease, cancer, respiratory disease, diabetes. So this is increasing order. So that means in your left side, that is the fourth leading cause, to the right side, that is the first leading cause. Okay? So anyone? How many of, so you had raised your hand, tell me the answer. C? C first? Anyone? You want to say B? Okay, let's see the answer. What is that? Yes. So Dr. Tanushree got the first prize. Madam, please note. So yes, medical error, they are the third leading cause of death in US after heart disease, cancer, and then the medical error. And you can see this beautiful girl, very unfortunate incident happened. This is due to a medication error. Something had been done wrongly while giving this intravenous bag of saline. So we lost this girl. We need to prevent this. So when we talk about this CPRRF today, I want to focus on this issue of prescribing cascade. To discuss prescribing cascade, I am selecting two cases. So case one, this is a 68-year-old lady who is suffering from osteoarthritis, hypertension, diabetes, ischemic heart disease. BMI is 36. Last 5 months, she is suffering from pedal swelling. There is both knee joint pain and severe weakness for last 5 days. You can see the current list of medications here, a long list. Along with that, she is consuming fixed dose combination which contains diclofenac occasionally. Sometimes back, 6 months, 7 months back, she was prescribed with this fixed dose combination for her low back pain by some orthopedic doctor for a certain limited period, 5 days like that. But as you know, our patient believe when they are feeling comfortable with some medication, they sometimes make that their habit too. So as she was suffering from knee pain, she was consuming that medication to relieve from the knee pain. And you can see the lab reports here, starting from the HbA1c, which is quite high, with hyponatremia, hypokalemia, eGFR is little bit deranged, other tests are okay. Now the second question, what is the most important cause of weakness here? The four options are poor glycemic control, chronic kidney disease, drug-induced disorder, and depression. Someone may believe if an option will be like that, all of the above, I think everyone will raise your hand, yes, it could be all of the above. But my question is, what is the most important cause of weakness here? Then what will be your answer? Yeah, so I think this is the virtue of Professor Tripathi sir's lecture. You now understood that drug-induced disorder is something we need to take care of. So, as the patient is suffering from weakness and pedal swelling, now you just think of this pill burden. So, the patient is taking furosemide for 7 days. Why? For pedal swelling. And for that, before, if you want to evaluate the pedal swelling thing, you check this medication list and you can understand what could be the reason behind that pedal swelling. Apart from that, if you again go back to that eGFR, that is below 45, and the patient is consuming metformin, a full dose, 2 gram, patient is consuming diclofenac. So this is critical issues. Now again another question, the drug group or groups causing pedal swelling, A, B, C, D, anyone? Which group you were suggesting that could be a right option? Anyone? A? You are telling A? Okay. Who is telling D? Raise your hand. You? So I think there is some confounders. Dr. Anindo is there. Your answer is right. So the patient is consuming pioglitazone, amlodipine, pregabalin, and patient is having pedal swelling. So without addressing that, some physician prescribe furosemide to control that pedal swelling. So this is why we need to suspect drug-induced disorder. Now again a straightforward question, as we are talking about prescribing cascade, which is the correct option then? A prescribing cascade occurs when A, B, C, D. So patient has an adverse drug reaction and additional drugs are prescribed to control the symptoms of this reaction without deprescribing. So that is prescribing cascade. Now again, you have to tell which statement is false in the context of this case. A, rosuvastatin is independent of eGFR. The dose of rosuvastatin is independent of eGFR, whereas atorvastatin dose is eGFR dependent. How many of you are agreeing with that statement? This statement is true or false? This statement is false. How many of you are agree? Dr. Deepan is there. You too? Okay. How many of you feel that this statement B, glimepiride, pioglitazone, pregabalin, domperidone can contribute in weight gain? This is true? Okay. Now, calcium citrate is better absorbed compared to calcium carbonate in background of chronic PPI usage. True. So this patient, this particular lady, was taking PPI for a long time. Along with that, she was consuming calcium carbonate. She was suffering from osteoarthritis. You know, the calcium carbonate containing medicines are too costly. Tramadol, the patient was also consuming tramadol. Okay? So, can tramadol cause hyponatremia? What is the mechanism then? Yeah, so that is syndrome of inappropriate ADH secretion, so CR. So that can cause hyponatremia. So the right answer, as you all mentioned, the first, that is, we should adjust the dose of rosuvastatin according to eGFR value, but atorvastatin dose is not eGFR dependent. This lady was taking rosuvastatin in quite a high dose at eGFR, which is low, that is below 45. So this was done, reconciliation. So in this case, one of the major issue is the body weight. We need to prescribe some medication which can also address the body weight. So we use this GLP-1 analog, dulaglutide, along with we reduce the dose of metformin. Initially few days with basal insulin because hyponatremia was there. Along with, after that we initiate the dapagliflozin. Paracetamol was started, as also Dr. Bakchi was mentioning the importance of paracetamol. They can be used in hepatic compromised cases too. The calcium citrate salt was used. Atorvastatin 20 milligram with aspirin was given. And also we deprescribed that domperidone, a dangerous drug, D for D. Why? Anyone? Specifically in elderly patient, that can cause some extrapyramidal symptoms. And also domperidone is sometimes prolonged QT. So this is the result. We were very happy with that patient. And sir was asking that whether the physician will be okay with this type of deprescribing practice. So we had published this paper in JAPI, and we are really fortunate that this paper was selected as second best paper in the name of Dr. G.C. Mehta, best case reports by the JAPI, and we got that award too. I think we have less time and I do not want to bore you with all these things more. I am just going down to case 2 because this is quite interesting. We had faced this case very recently. This is a 67-year-old female, diabetic, hypertensive, CKD, admitted in CCU with CVA, started piperacillin tazobactam for unknown reason. Initially, today's morning, Dr. Shreyoshi Dasgupta had presented a paper where he had shown prophylactically antibiotic was used. Sometimes 2 antibiotics were used. We don't know the reason. Prophylactically, why we need 2 antibiotics. Many cases she had found. So in this case, CVA started with piperacillin tazobactam, 8 hourly. After 5 days of admission, temperature and the heart rate. Blood culture sent, it was report pending. What happened after 5 days of admission, as she was suffering from that fever, she was taking piperacillin tazobactam. The treating physician thinks to increase the dose, increase to the higher range of antibiotic. Imipenem cilastatin was initiated 8 hourly. So day 7 of admission, what happened? There is 3 episodes of generalized tonic-clonic seizure, fever with chill, and that was persisting, no relief from the fever. To control the generalized tonic-clonic seizure, they had used injection lorazepam at 12:30 am because that was the time when she was suffering from that GTCS. What happened after giving lorazepam? The patient deteriorated immediately, saturation is falling down, drowsiness, need of intubation and mechanical ventilation was given. Now next day, all those neuroimaging done, echo done, everything normal. Routine blood test, okay, only the creatinine elevated to 1.9. Obviously, lorazepam was not continued, levetiracetam was given. Day 9, still fever persisting and the blood culture sensitivity report came, no growth was found. Now, they had stopped imipenem cilastatin. Suspicion was that this is a case of drug fever. Or just after 4 hours of discontinuation, the patient became a febrile. Ultimately discharged after 15 days of admission. So patient was admitted for ischemic CVA, just a lacunar infarct, and for 15 days she had to stay in hospital. For what? Just for some new symptoms, new disease that occurs due to drugs. And which type of drugs? Unnecessary drugs, unnecessary use of antibiotic. So which statement is not appropriate in this case? Diagnosis written in discharge paper, type 2 diabetes, CKD, CVA. Number 2, carbapenem can cause seizures by their ability to bind GABA receptors and inhibit that GABA response competitively. So whether it is true, if I am telling this instead of carbapenem, I am telling beta-lactams, then is it true or partially true? Then I have to change, it is not competitively inhibit. It is non-competitive inhibition of the GABA receptors. So relative bradycardia and rapid recovery after de-challenging offending agent, these two are important feature of drug fever. Is it true? This is a classical features of drug fever. One is relative bradycardia and number 2 is rapid recovery after de-challenging. And here I want to emphasize on this point, the EGFR value, which considered here inappropriately, specifically when choosing imipenem cilastatin, leading to overdosing of imipenem. There is no doubt in that when we talk about in critical care setting, the antibiotic dosing, we need to use not to rely on only the EGFR value. We should rather follow the rule of loading dose there. But you can see for 3 days the patient was taking imipenem cilastatin in that dose. So if you consider this particular lady, the EGFR was calculated in CKD-EPI formula and it comes under that 35.1. When we dose imipenem cilastatin, this is the prescribing information, the label, and you can see it comes between this 60 to 30. So 500 milligram 8 hourly is okay. Then if we calculate like this, so according to the CKD-EPI formula, the dosing is okay, fine, normal. But this is important message. To calculate specifically this antibiotic dose, imipenem cilastatin, the EGFR calculation should be done by Cockcroft-Gault formula. This is important when the patient's body weight is lower. And in this case, we need to consider that body weight. It is 48 kg. And if you calculate it with this, the same EGFR, it becomes 25.85. So instead of 60 to 30, it should come under that 15 to 30 group. And ultimately, the dosing was inappropriate. And even if in this EGFR, we should continue this 500 milligram twice daily dose. So this caused the prescribing cascade. And what is the prescribing cascade here? First of all, the piperacillin tazobactam was used, and that piperacillin tazobactam, inappropriate use of piperacillin tazobactam caused drug fever. Without understanding that is due to the piperacillin tazobactam, what had been done? They had given imipenem cilastatin. So now the imipenem cilastatin use, which was again little bit overdose, that caused a seizure, generalized tonic-clonic seizure. So second adverse event, second drug-induced disorder. And what happened? Next, the third drug-induced disorder. To control that GTCS, they had given the lorazepam, but unfortunately, lorazepam caused respiratory depression and drowsiness, which leads to mechanical ventilation. So this is a case of prescribing cascade. So that is why we need to reevaluate the absolute need of offending agent using non-pharmacological treatment just to do deprescribing. We need to calculate the dose properly and consider alternative drugs. So good prescribing is not a snapshot, it is a continuum, starting with therapy initiation, with dose titration, with changing, adding drugs, switching or ceasing drug therapies. I am not going in details, there are different concepts. Just finish with these challenges for us clinical pharmacologists. This clinical pharmacology, reconciliation, review and feedback, this concept can be applied by any discipline. It is not exclusive to us. It can be done by internal medicine specialist, cardiologist, gynecologist, surgeon, if they can do. Our job is, yes, to also increase the awareness about this concept among them also. Even we can improve ourselves if we address these challenges. First of all, the number of specialists providing this service, if we can increase the number of specialists. If we are talking some clinical exposure lack in our postgraduate training, if we can improve that clinical exposure, awareness level and confidence of other clinical colleagues on this concept, obviously the willingness of administrators is extremely important, and last but not the least, clinical pharmacology therapeutics, it is not always possible to become a master of all, because if we want to become the jack of all trades, we can become the master of none. So it is also important to select different subspecialty domain, maybe one or two, and whether we can become the master of those particular therapeutics area, that we need to think about. Thank you. I think I will not stay standing between you and the prize distribution ceremony. Thank you. Only the last question, this is for me. Dr. Shabna madam told me she will give prize to me if you give the right answer. What, in a 2 word, if you want to describe this picture, what should be that 2 words? Thank you, prescribing cascade. So ultimately, I also will get a 1 prize from madam. Thank you.
Thank you, Shambo. So we finished with this last presentation, which is actually the core of clinical pharmacology. We all understand that. And it's great that you demonstrated that by case studies. I truly believe that case study is a wonderful way to understand these things. But for students, I think once you look at that case study, it's just not just looking at that case study and understanding what happened. You have to go back into the mechanisms. mechanisms of how all these, the first drug is causing the first adverse event and how the next drug then gets added, what the clinician's thinking is, that's one. The second thing I think you have to do is, as Shambo rightly pointed out, we can't be masters of everything. On the one hand, we can concentrate on one specific area, but apart from that one specific area that you might choose, you also need to look at what are the most commonest drugs that are most frequently prescribed. And at least for those drugs and for those conditions, you should have a very clear understanding of how these drugs work, what are the side effects, what are the rare ones, which most people will miss, but as a clinical pharmacologist, it's our duty to be able to spot. So, I think, this presentation really helped do that. Any questions for Shambo here?
If I am allowed to add any comment on this. Yes, I agree that not trying to be master of all, but at the same time, my clinical colleague would like to look at me that as a specialist whether I can try to address the problem he is facing. If at all someday they feel confident to refer patients to us. And from that angle I would say there is a case in trying to be jack of all. And by this what I mean is think of, I'm trying to draw an analogy with a legal expert. When you visit your legal expert, do you expect that overnight he is going to solve your problem? It takes long time. Many of these kind of problems doesn't require an immediate kind of solution, and nobody is actually expecting. You receive the problem, take your time. Most of these problems will require, maybe if you can give this next day, the solution you give the next day, good, fair enough. And that by that also you can help. Nobody expects you are a moving dictionary, you are a moving Goodman and Gilman. Immediately you give your response. No, not necessary. But you have the wisdom to look at which page of the Goodman Gilman you have to look for, or for that matter, what reference. That might be lacking in your clinical colleague. So you should have the ability to analyze the problem, try to find the right answer from the extensive literature that are available, and get back to your clinical colleague. And for that you tell it. Trial takes a 24-hour time. Okay, my turnaround time is 24 hours. Even if you go to a microbiologist, he is not giving you immediately a solution is not given. So take your time. 24 hours, 48 hours. But then during these 24 hours, you have to do your diligence. Okay? And apply your wisdom. The answers are there in the cloud, but you have to pick and choose. Okay? And then contextualize it in the given case scenario, and then give you this thing. And use your DM degree, that you are vouching for this. And that's what I was also mentioning, that you have to protect your clinical colleague. Medical legally it also becomes sound. He finds comfortable then, yes, I have got this advice from a clinical pharmacologist, my learned colleague, clinical pharmacologist. So I would try to look at this way. Thank you.
Absolutely, it's very well said. Thank you, Shantanu. If there are no other no questions or no other points of discussion, is there one, Dr. Bagchi? No, I thought you were putting your hand up. Okay, then we can close this session now. Thank you. I thank the audience for being here till the end of the day and listening to this. And I think you would have missed something if you hadn't.
It was very useful, particularly
Very useful.
of what you have mentioned yesterday in your oration.
Yes.
About clinical pharmacology consultation.
Absolutely.
Now gradually you are understanding there is a case for it.
Absolutely. Yes.
Whatever has been discussed by and suggested by Professor Tripathi sir, actually I can share my personal experience. I have an experience of working both in private sector as well as in government sector, and private sector as a clinical pharmacologist in Apollo Hospital, Kolkata, many years ago. And I was a person who initiated this service, particularly in this critical care setup in this particular hospital many years ago. There's a first time in Eastern India, and Apollo was then first appointing the clinical pharmacologist. It is a story of 2006. After passing my MD, I was doing this service. In fact, I can share this to the youngsters that it was the very first day when I joined into this post. Actually, I seek help from Sir. Sir was active on MSVP then in IPGMER, and Professor Abhijit Hajra. These two doyens helped me a lot in implementing this service there at Apollo Hospital. Nobody knew by that time because the administrator didn't know about it, the physicians didn't know about it, how they can utilize a clinical pharmacologist there. The very first day I can remember the pharmacy head, actually they were then working in consultation with the Apollo Chennai. The Apollo Chennai and Apollo Hyderabad by then appointed a clinical pharmacologist. Apollo Indraprastha still they didn't appoint. And then he said, please you visit our critical care consultant. He is the first person, right person who can guide you how to implement this service there. And he is a person, he is still working there, he is the chief of critical care in Apollo. He is a South Indian, Dr. Suresh Ramasubban. He is a US trained, he is US board certified critical care consultant. He knows how to utilize a clinical pharmacologist in this critical care setting. And the very first day when I met him, I found the right person. So he then first, he spent around half an hour with me and he said that how these things happen in US, and he described everything to me, that what is expected from you. And mind it, one experience I had from IPGMER hospital, I did my MD from IPGMER, one very good course curriculum was there. By then, we had to spend in the clinical departments for consecutive 6 months at a stretch, without visiting our parent department. Only we needed to visit our parent department in case of seminars and journal close presentation. And we had to take the clearance from the clinical department before joining our pharmacology department. And that was under Kolkata University, that curriculum was there. But that was abolished under this Health University. Now the NMC is vouching for the same. And I have learnt a lot of this clinical care during my attachment in the cardiology department. In this cardiology department, they used to apply this Cocktail formula, this MDID formula, this hepatic drug calculation in the critical care unit, and I have learned this in regular ward round, and I have been in practice in doing the same everyday clinical round there. So that experience helped me a lot in implementing this service there in Apollo Hospital. And within 6 months, I have developed that service. We did regular critical care round. There are 7 critical care units. Nowadays, it has been increased to 12. And in consultation with the clinical care consultant, he advised me to utilize Sanford guideline for antibiotic policy. It's still available. I do have this. I carry this one for our setup also. And I have utilized BMJ. It is not BMJ, BMF. BMF for this day-to-day drug dose adjustment. Dr. Abhijit Hajra has given me that BMF copy. He is a keen follower of BMF. He carries all the BMF editions with him till date, and he has given me that copy. And I used to carry that BMF along in my apron, and I used to make round there. I had to adjust the doses, drug doses, including every critically ill patients. I gave feedback to them, and they referred the cases to me. So this was my experience. So how this way you can implement this service in the critical care setup that is mostly sought after area for the clinical pharmacology application. So this is my humble, and now we are applying the same in the topical medicine as well. Here one great initiative has been taken care of by the ID specialist. Every week we are having a multidisciplinary case discussion meeting on every Wednesday in School of Tropical Medicine. They have started DN Clinical Pharmacology and ID course also. They have excellent teachers, excellent young stars coming from AIMS with DN ID qualification. We have very good interaction there. We have pathology department, we have a very good microbiology department, we have clinical pharmacology department, and they refer the cases to us. We regularly receive the referral from the ID departments for this drug, for soliciting these drug-related problems. And I am personally taking charge of this standard treatment guideline, convener of the standard treatment guideline formulating committee, and we have completed the same. It is going to be published recently. So we are planning to do hospital antibiotic stewardship there, and it's a big issue there, and we are hopefully will be able to do it in the coming month. So we are now in this way, we are approaching and we are applying our concept into this clinical care, and our administrator also helping in this regard very well. So thank you very much. I wanted to share this with the youngsters. So hope for the best. Thank you.
Thanks for sharing that, really. Closing comments?
Felicitation then. So I would like to invite Professor Shantanu Kumar Tripathi sir, and to felicitate him, I would request Dr. Shovan Mukherjee sir to please come up onto the stage. So you are felicitating? Sir. Yes.
I've learned after felicitating so many people.
I would also request Dr. Shovan Mukherjee sir to please stay back for the felicitation of Dr. Chiranjeev Bagchi sir. Okay. তোমার ফেলিসিটেশনটা করে নি স্যার দাঁড়িয়ে রয়েছেন স্যার ওয়ান মোর ফেলিসিটেশন দ্য ফাইনাল ফেলিসিটেশন অফ ডক্টর শাম্বো সমাজদার probably sir he is the best person to answer that question. Okay. So Dr. Shubhadeep Sinha sir has commented, what a picture, two of the living legends of clinical pharmacology in one frame. Hopefully in the next conference we will be having more such clinical pharmacologists in a single frame, all the stalwarts together. So
Professor Shantanu Tripathi and Dr. Shovan both have been mentors to countless pharmacologists and clinical pharmacologists. So if you can call, like some have been Arjuns and some have been Ekalavas, but they have been Dronacharya for all of us.
indeed sir.
Another prize. Up to this point you are showing interest. So you have gone back and still you are looking at the conference proceedings. That's great.
I wonder sir whether you have been able to hear what sir had just commented. Sir has appreciated. Yes, sir has
Yes, but I have not slept off. I have not slept off during the conference. I have not gone elsewhere. I have been listening throughout. Because very rarely does a pharmacologist get invited to a clinical pharmacology conference.
Anyways, thank you so much sir for your participation. Next we will move on to the valedictory session. So I would like to invite Professor CPRRF sir to please come onto the stage to announce the prizes.
Is this one?
Hello, Dr. Sinha sir. Can you hear us, Dr. Sinha sir?
Message.
Hello?
Yes.
So we need Sinha sir's approval. If I say he don't accept it.
Hello, Dr. Sinha sir, can you hear us?
Yeah, I'm there.
Yeah.
Please. Don't ready, go to the mic.
Both I and sir have so I want just sir to say a few words.
Dr. Sinha has provided the support.
It was quite an interactive session, although I kind of interfere in between too many times. But the best part is that So all the students, they have, all the participants, they have done the studies in a very resource constrained settings. And despite, at least they should get a applause for the, if not, even if they have not got the prize, for the effort that they are putting in for doing these studies, whatever they can do under the settings, and they really deserve that. This shows the intent and their talent, and despite hardly any support, they can do this. When they have a lot of support, I think they can do much more. That is one point. And secondly, I think Prabhakar, you announced that part. I think what we have discussed regarding the award.
So it is better to announce. I think we can ask all the.
No, Dr. Shubdeep Sinha requesting you to announce the next part. What you have discussed, both of you have
No,
discussed.
that award related.
Achha, award related, okay.
Awards, only awards.
Okay.
I think we can ask all the competitors to stand up.
Please stand up.
So one thing here we have decided is, as I was speaking with Shambo, we are planning to give second prize for oral instead of poster presentation.
Okay.
So with the permission of him, we have given a second prize.
What about poster? There was poster.
There was 4 posters,
But,
but actually they were not, according sir will tell.
Okay.
So we just wanted to, the last time what happened, it happened the same way, but we didn't give for posters. So this time we want to convert that to this one also.
So does that mean that you are
No.
giving 2 prizes to oral, but no prize to the poster?
Poster. So this will not repeat, sir.
But that is due to some scientific value.
Okay.
So
this will not repeat, this is a one time,
Okay.
because we want to encourage
Amalgamated all
them.
of them and
Okay.
then chosen the 2 best which turned
Okay, I
out to
understand.
be orals.
So this is what we have done. This is a one time process where when we get next more things, we will do it that way, sir. So first we have seen whether it is having any clinical relevance to society. If you are going to put your study into society, is it going to be useful or not? So next time what we'll do is we'll frame a criteria for selecting. And the first thing, remember, it should be ethics committee approved. Okay? That will be the first point. Ethics committee approval. Without that, you should not, you should not even send it for acceptance for your this thing. Just please see that. It's not only for you, even for your guides, because it might be a violation. Okay? So here first prize goes to, any expectations from viewers? Yes? Somebody is holding back hands like this.
I think that we can announce the second prize first.
Okay. Second prize, any expectations? So this was very good study.
Everybody is expecting the first.
Except him, sir. But we have to satisfy our, we have to keep our organizing secretary happy. So we listen to our organizing secretary. So the second prize goes to one study that was done on FDC.
Good.
Who is it?
Yes. What is the number? 4, I think. Yes, Dr. Palomi Ghosh. Congratulations. So we expect you to do the full study, present it in your department, present it to your hospital whole institute, where they will come to know what are the FDCs that were not being prescribed as per regulatory system. Okay, so we want you to take it forward and see that this, see that we are becoming more useful to the society. Okay, congratulations. Any words, sir? This is the second prize.
So first and second doesn't matter, all are winners, and that subject is very topical and it is very important in today's pharma industry, that India is flooded with fixed dose combinations, and there is a lot of struggle for the last 10 years to weed out mostly irrational FDCs. the intent is very solid, and please keep it up and do much more studies on this subject. India needs more such efforts. Thank you.
Thank you. So, that's that. Sir is there. We like direct everything to sir. So elder people have to bless us, including sir. Okay, we are small people in age, and so we should not do that. Okay. This first one, any expectations? I gave a hint. I gave a small hint while I said somebody folding their hands like this. So, Dr. Shravan, might be the results are not what we want, but this is going to play a major role in future, where genetic polymorphisms may go for personal license. So we want you, and remember, in Olympics there is a saying, it's not who wins, it's whether you have participated or not. That is more important. Okay? So, best of luck, and see that you do more of these things. Okay? Congratulations.
Congratulations.
So, one small photo for all participants.
With the first and second.
First, second, and sir in background.
Yes. So please.
Yeah, Santanu sir and Shoimal sir should also come.
Okay. You want us to participate and compete? No
No,
way.
No, sir.
no. I mean to say
I understand, I
the real guru should be there.
Sir, we will do that one. We also will participate, but Hetero should sponsor the first prize. Sir,
No, we can't say that now.
No, we want Hetero to sponsor the first prize.
No, we can't say that now, sir. Now the NMC guidelines.
No, we will say Dr. Sinha sir is sponsoring.
Oh, okay, I'm sorry. Okay.
So the first prize in Dr. Naidu's name, second prize in Shobha Madam's name.
Please go.
Sir. You can come. Shambo. So who is going to give now, sir? you should not come here. First we are giving second prize. We will take all the contestants.
All the contestants.
All the content.
All
Yes,
participants
all
come.
Participants. It's small. Sir is becoming prominent. Some more from this side.
Some may stand in front also.
Sit down there. That is it.
Someone sit down.
In front. Sit down. Here. Okay.
মুখটা গাঢ় হচ্ছে না
You can.
ঠিক রেডি রেডি স্যার মুখটা গাঢ় হয়ে গেছে
You come this way.
You can come this side because this side is khali.
রেডি once more থ্যাংক ইউ
বাকি সবাই চলে এসো।
তামসিয়া চলে আসুন
সবাই চলে
তাহলে উনি তুমি এসো
বড় বাচ্চা উপরে।
তুমি ওপরে এসো
সামনে বসতে হবে
হ্যাঁ সামনে
সামনে বসতে হবে
দেখা যাবে না
দেখা যাবে না সবার মুখ
চলে এসো, রোহন চলে এসো, আমি আর রোহন সামনে বসছি, চলে এসো, এটাই তো ভালো।
যারা লম্বা যারা বসে থাকবে
From this side.
আরেকজন বিপন চলে এসো। আপনি
এখানে একজন চলে আসুন আপনি এদিকটা চলে আসুন ম্যাডাম আপনি এদিকে চলে আসুন
চলে এসো।
এইদিকে চলে আসো।
একজন এদিকে চলে আসুন
Some chairs in between.
যে আসলে স্যার
Chairs.
এবার মনে হয়ে যাবে।
না, এখানে সামনে চলে আসুন, নিয়ে আসুন।
স্যার
স্যার ওইখানে উপরে এইটাতে স্যার আপনারা এমনি পেছনে দাঁড়িয়ে যান, হয়ে যাবে।
আপনারা দুজন স্যার বসুন
আচ্ছা,
না না না, আমি এখানে আছি।
আমি এখানে ঠিক মধ্যখানে দাঁড়াচ্ছি মধ্যখানে দাঁড়াচ্ছি
স্যার শাম্বু তুমি সামনে বসে ব্যাস দাঁড়িয়ে
এবার একটা পার রেডি
ক্যামেরা বন্ধ করে দাও ক্যামেরাটা
রেডি
ফোন বন্ধ হয়ে গেছে আসছে
এক মিনিট দাঁড়াবে বন্ধ হয়েছে
people in online would appreciate certainly that it was, the conference was academically quite sound and rich. The participation or the number of people physically present might be low. There might be a few more people online, but otherwise subjects, topics that have been discussed, they were very relevant. There were also very lively interactions. And as we leave today, at the end of these 2 or rather 3 busy days, we go with more clarity on the role of ourselves and the role of, or the place of clinical pharmacology in the overall perspective of patient care as well as regulatory science. Hopefully, the society will find its more rightful place in the therapeutic environment, treatment environment, as well as access to affordable care in the country in years to come. Thank you very much. Thanks everybody. Special thanks to the organizers led by Dr. Shambo Samajdar. A big hands to Shambo and his team. Thank you. And I must thank Dr. Shaival Mukherjee to have this patience and care shown to us. It's a great encouragement, and thank you again, as I have always been your admirer since the first day I met you. Thank you.
Of the organizing
Yes,
team
of course.
is really fantastic, wonderful.
And we'll be not doing our duty if we do not mention particularly about this institute. They have given a huge support. Thank you. Thank you, Medica, for your support. So all of us.
पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल जमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे